Assalamualaikum semua. Boleh dengar tak?
Dengar je, saja je nak masuk dalam rekod kan. Dengar tak saya cakap?
Dengar.
Okey.
Hello. Korang dengar tak? Hello, dengar?
Dengar.
Dengar. Jelas tak? Jelas. Hello?
Slow.
Slow sangat?
Slow sangat.
Hello?
Slow, sayup.
Hello? Dengar?
Better.
Oh, okay. Tak payah pakai ni earphone dah.
Tapi ada background.
Tapi ada background.
Okey dah.
Okay. Okay lah. Tak payah pakai. Hello? Okay, dengar kan?
Assalamualaikum.
Waalaikumsalam.
How are you?
Waalaikumsalam. Better.
Uh,
Alhamdulillah.
Alhamdulillah. Okay. Hoping we can get some more practical point, inshallah, for our session today. Is it alone cases also? Okay. Who will be our presenter or first team?
I will be the doctor and Asfar will be my patient.
Yes, I'll be the patient.
Okay. Who will be the Uski?
Me
It will be me and Afika.
Oh, mashallah. Good. So let us start by Al-Kitab. I hope everyone will switch off his phone, his voice, please, so we can concentrate with our team. Try to increase the volume of your voice, both the patient and the doctor. And we try to regulate the time, inshallah. Okay? Because working under stress is the usual in medical field. So to be arranged is better. Let us start by Al-Kitab and go ahead after that. Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alamin. Ar-Rahman ar-Rahim. Maliki yawmiddin. Na'budu wa iyyaka nasta'in. As-sirata al-mustaqim. Okay.
All right. So, Assalamu alaikum, Asfar. Mr.
Waalaikumsalam.
Asfar.
Yes, my name is Asfar.
Who did you bring with you today?
So this is my son's Ahmad Daniel. 7
How
years
old
old.
is he? How old is he?
7 years old.
10 years old. And why did you come to the hospital today, Mr. Asfar?
My son's like he's having like headaches for 2 months already.
Okay. Did he describe to you the type of headache he's having? Does he complain of any-
Pardon, I cannot hear you.
Did he describe to you the type of headache he's having?
Yes.
Okay. Can you please describe it to me?
He said that the headaches was like I'm trying to ask him where the headache is located. So he said that it was generalized, and he said that it happens nearly every day, and usually it was during early morning, during wake up from sleep. Yes.
Does it happen after he wakes up, or does the headache wake him up from sleep?
After he waking up.
Okay. For 2 months, is it every day, and is it getting worse or is it getting better?
It's every day, but I don't think it is getting worse. So the reason I came to hospital because he's having like he cannot walk properly. Like his walk was very unsteady for 3 days. Then I worry about him, so I brought him to the hospital.
So he can't walk properly for 3 days.
Yes, cannot walk properly. It's like his walk is very unsteady.
Okay. Has he fallen, or how would you describe his walk?
He can walk, but he just like unsteady, like can walk, but like
Alright.
like he like that.
So this happened 3 days ago.
Yes, 3 days ago.
Has it been getting worse, his walk?
Pardon?
Has his walk been getting worse?
I think not, but yeah, I'm worried about his walk, his walking, his gait.
Okay. Does his unsteady walk also associated with his headache, or as his headache gets better, his walk gets better?
He's still having headache, but I did not know if the headache is correlate with the gait.
Okay. All right. Apart from his walk, is he telling you anything else, like he cannot hear properly or he cannot smell properly?
Oh yeah. Actually, he's also complained to me that his vision is like he can see like things double, like he see things like double vision.
Okay. For how many days has this double vision been happening?
The double is quite long since I think quite a month, 1 month, 1 month
For
ago.
1 month.
1 month he's having like double vision.
Okay. For his double vision and his headache, did you seek any medical attention before that? Before coming here?
No, because I think like maybe it's just a normal headache. Like he did not
Okay.
really complain it.
Did you give him any Panadol at home or anything?
Uh, mm, no, because usually when he's having headache,
Mm-hmm.
like in the early of the morning,
Okay.
he will like vomit after the headache. Like
Okay.
after his vomit, then the headache like usually like reducing, like resolve after that.
All right. So apart from this vomiting, is he having any diarrhea?
Diarrhea? No, I know no diarrhea.
Can you tell me what's inside his vomit and what color is his vomit?
Usually is a fluid content, and usually in the usually because it's in the early morning, so usually it's like a fluid. Sometimes a food, like if it's like
Is there
taking
any blood
taking
inside his vomit?
what?
Is there any blood? Or is it like brownish in color? You are muted, Aswar.
Okay. It's just a clear fluid, and sometimes it like a food content.
Okay. After he vomits, can he eat normally or no?
After his vomit, he was able to tolerate already.
Okay. So you told me that he has double vision for the past month now.
Yes, for the past month.
Okay. So in this double vision, have you seen him change how he acts? For example, he's 7 years old. So I think he can scribble a little bit.
I cannot hear you.
Is there any changes in the way how he acts?
Oh, like when he was about to read and writing, so
Yes.
usually he had to close his eye.
Okay. Which eye?
His I think is his left eye. Yeah, his left eye.
Okay. And when he closes it, he can read and write normally.
Yes.
Okay.
Oh, due to this double vision, I brought him to the optometrist clinic.
Okay.
Okay.
And what happened there?
But in the clinics, like he said that it was like normal. I don't know about that.
Okay. So when he's having the double vision, it's
Yeah.
1 month, but only 3 days ago he started walking unsteady.
Yes.
During that double vision, did you also notice any abnormality with his gait?
Oh, his eye like uh juling squint. He's having like squint over the left eye. Yes.
So his eye is his lid drooping, or is his eye not following the other one?
Oh, I'm not sure about that, but I can see that his left eye is squint like more towards medially. Towards medial.
Okay.
Okay.
So it's going inward.
Yes, inward.
Okay.
Medial. Okay.
All right. So is this squint on and off, or is it getting worse ever since that 1 month, or is it getting better and like go back to normal and
I
then?
think it's not getting better lah, but I'm not sure if it is getting worse or not.
Okay. So I'm just gonna ask you, before those 2 months where he started having these headaches, was he okay? Was he normal?
Yes, he was normal.
Okay. Did he ever complain to you that he cannot see bright light?
Oh
Or
no, he can see bright light.
okay. So did he ever complain to you that his neck hurts or he
No,
cannot move his neck?
he did not complain that he's having neck pain.
Okay. did you ever notice that around his body he has like a rash or
Uh,
discoloration?
no,
Okay. And he hasn't had a fever or flu
no,
before?
no fever.
Okay. No flu or cough as well?
Yes, no flu and cough.
Okay. So was there any change in the way how he acts?
No,
Sorry,
no,
my
no. I think no abnormal behavior.
Okay. Was he all of a sudden shaking? If you know if he had a
No,
fever or
no,
not?
no.
Okay. So did he ever like faint?
Like what?
Faint.
Pain, pain,
Faint.
pain. Like sakit, pain.
No, faint like
Oh, pain.
loss
Oh,
of
yeah.
consciousness.
Sorry. No pain.
Okay. So have you seen that his face, other than his eye, his face is like not the same from one side to the other?
No.
Okay. Um, so all right. So I'm just gonna ask you about his development.
Okay.
So can you tell me if he hit all his milestones?
I think his development is up to his age. Like it's not his growth normally.
Okay. So is he vaccinated as well?
Yes.
Okay. Did he fall down? I'm sorry, I did not ask that.
Fall
And
down?
hit his head? Did he fall and hit his head before he?
No.
Okay. So is there any history of cancer in your family? I'm sorry, sir.
History of what?
Cancer in the
Oh
family?
no cancer.
Okay. Does he have any complaints where he tells you that his heart is beating too fast
No.
or that he's tired easily?
No.
No. Can you tell me about his birth history?
Oh, birth history. Actually, his mother is having like problems during her pregnancy. Like this is his birth was at 33 weeks. Yes,
Okay.
33 weeks. And also his mother during pregnancy, like I'm not sure, but the doctor said that my wife like having like bleeding inside the like inside her
Okay.
uh,
Does the bleeding come outside or stays inside?
like bleeding inside.
Okay.
I'm not understand what the doctor said.
Okay. He was born at 33 weeks. Did he
Yes.
go to the NI?
Yes.
Okay.
He goes to the NICU for 2 weeks.
Okay. Do you know in his history inside the NICU if he was intubated? If
I'm
they
not
put the
sure about
tube
that, but
inside his mouth or
I'm not
anything?
sure about that, but I think my son's like he's having like yellowish in color,
Okay.
and he's like at that time he was like on like what's that light things like the purple.
Okay. So they
Uh,
put him under the special light.
yes.
Okay. For how long?
1 week. I think one weeks for
Okay.
that light. Yes.
All right. For 1 week. So can I just ask about his feeding history? Is he eating normally? Did you notice that he doesn't have appetite or he lose weight?
Um, his his eating habit was normal.
Mm-hmm. Was he breastfed when he was
Oh
younger?
no, he was not. He was not breastfed. He was
Okay.
started on formula feeding since birth.
Okay. So right now he eats normal adult diet.
Yes, on adult diet.
Okay. So I wanted to ask about your family. How many children do you have?
Mm, I have 3 children.
Okay, he is which one?
He is the eldest one, the first one.
Okay. How about your second child?
Um, he's healthy,
And your third child?
also healthy.
Okay.
Actually, I usually have supposedly to have 4 child, but
Okay.
there was the youngest one, like 2 years ago. My wife like pregnant and have like during the birth like my child like have a sudden death, and the
Okay.
doctor said that he's like lack of oxygen.
Okay. How old is your wife?
My wife. Yep. My wife. I'm not sure. The guess right up.
It's okay. How old are you?
I'm also not sure about my age.
Okay. Um, can I just ask you about your family?
Okay.
So, or even in your child, you noticed you said that he doesn't have any discoloration on his skin. Do any of his siblings have that, or maybe your wife?
I don't think so. No.
Okay. So there's no like freckles or like little tiny bumps on their skin or around their eyes.
No.
Okay. So my second question will be, does does Ahmad or any of your other children or your wife or anybody in your family have like other vision problems?
No.
No, they don't complain of like pain or like
No.
feeling tired all the time or being a little bit dizzy.
No.
Okay. Is Ahmad potty trained?
What?
Potty trained. Can he go to the toilet by himself?
Yes. Yes.
Okay. Alright. What else am I supposed to ask? How about your work, sir? You know
My.
about are you or your wife working?
I'm not sure.
Okay.
I'm not sure what.
Um, you live. Do you know where you live?
I live in Kuantan, in Sungai Karang, Sungai Karang Damai.
Okay, I'm gonna pretend to know where that is.
Okay.
Just to clarify, apart from his eye, he does not have any other complaints of like his ears or his nose. He cannot
No.
hear properly, and
No.
there's no like
Just his vision only.
okay. And his face is symmetrical.
Yeah, symmetrical. I
Oh,
think no asymmetrical.
okay. So I think I have all that I need to. Did I surpass the time? Okay. Um, I, should I give the summary now? Did I miss something? Hello?
You still have some, yes.
Okay,
Ask
so
yourself what else.
okay, I will just recap my information. Asfar, can I ask you to clarify again? His headache you said is usually in the morning.
Yes, in the morning.
Yeah. Does his headache wake him up from sleep? Like does he complain? Or
I
does he
think
wake
his
up in
headache
the middle of the night?
did not disturb his sleep. Usually the headache was during morning. After he's waking up, then he like having headache.
Oh, so it doesn't disturb his sleep at all.
Mm.
Okay. All right. Does he complain that his arms and his legs are tired?
No. But yeah, he's having like difficulty to walk, like have unsteady gait.
Okay. But his arm and his legs are still okay.
Hmm.
And he did not have any flu or cough before this. Okay. This apart from his morning vomiting, does he vomit throughout the day as well?
No. Usually in the early morning, then his headache will usually like resolve after that.
Okay. And is his can you tell me about his vomiting? If it's like very forceful coming out of his mouth?
It's like a normal vomiting. It's non-projectile.
Non-projectile. Okay. And it only happens how many times per day, for example?
Usually 1 to 2 times per day.
In the morning as well?
Yes, in the morning.
How much is the amount? Like, is it 1 cup or half a cup?
The amount, I'm not sure about the amount.
Okay. And when you went to the optometrist, he said everything was normal?
Yes, the optometrist said that it was normal.
So your child or Ahmad does not wear any glasses, does he?
No.
Okay. Okay. Is his eye swollen?
I think it's not swollen.
Okay. It's not red or anything. Okay. Oh, okay. So my time's up.
Okay.
Okay. So I will give the summary.
Very, very difficult father. He doesn't know. He doesn't know anything. Why Azhar? Azhar.
Yes.
You have lack of
It's
knowledge.
not enough information.
If you are in real life artisting, you can be. But if we need to give the scenario, you must choose answer related to your knowledge about the case also. Okay, it is best. So can you do summary for that, Dua?
Okay. Can I just ask one more question before I summarize? No. Okay.
Once the bells ring, no way.
Okay.
One way. It is one way only.
So I'll try to summarize and maybe include what I didn't ask. This is a case of Ahmed, a 7-year-old Malay boy who presented with history of headache for 2 months duration. Headache was generalized in nature, happening daily during the early morning, but does not affect his sleep. It was also associated with vomiting 1 to 2 times per day, non-projectile in nature with clear fluid. He also presented with diplopia or double vision happening for 1 month duration with complaints of squint at the left eye. And he is also presented with an unsteady walk for the last 3 days that is worsening in nature. He has no discoloration on the skin. There is no complaint of neck stiffness. There is also no complaint of other cranial nerve palsies or abnormalities. He does not complain of any weakness or lethargy. And there are no bumps throughout his skin. And there's no family history of malignancy. Okay.
So what's your working diagnosis?
I think my working diagnosis in this case would be increased intracranial pressure secondary to a space occupying lesion.
Very good. What is the signs of ICP?
So in this case, the signs of his ICP will be his early morning vomiting, as well as his diplopia. That's the space occupying lesion.
Early morning headache also is significant.
Okay. So the point 4 is the neurologic, his headache, his blurred vision, his vomiting, and his weak, his unsteady walk.
And for a period of, it's very important.
For a period of 2 months duration.
So it's chronic one.
Oh, okay.
Okay.
Is that why his vomiting is not very projectile?
Okay. Is there any fever?
No. No history of fever.
No history of fever even at the start?
No.
Okay. So what can be the cause of this ICP?
Space occupying lesion.
Okay. Other?
Aqueous duct stenosis.
Okay. Other?
I want to say meningitis, but he did not complain of any neck stiffness. And there has been no trauma, like he did not fall and hit his head. So there, another cause can be hemorrhage as well, either intraventricular or subarachnoid hemorrhage.
Okay. What else?
Brain tumors.
Okay. What is the most common brain tumor?
In children, primary brain tumors.
Usually most of the tumor are primary. Okay. What is the type? Supratentorial, infratentorial? What is the most common type?
Not sure about that.
You can share here, Azhar. Don't say I don't know now. Other differential diagnosis.
So my other differential diagnosis, I think I want to put meningitis up there because he had headache and vomiting. But he points against if he had no history of fever or any previous infection prior to this.
Yes. There is something known as chronic meningitis if there is meningitis more than 4 weeks. But I think it must have evidence for infection like that. Yeah. What else can be? Azhar.
Can we consider like stroke? Pediatric stroke.
Stroke. Okay, what type of stroke? Should speak about hemorrhage. Two types
stroke.
of
But
other stroke.
Usually it's acute.
What other type of stroke other than hemorrhage?
Ischemic stroke, but
thrombosis can occur if the patient has protein C, protein S, some coagulopathy can be. Okay. So what other diseases we must think about?
Hypertensive encephalopathy.
Okay. Can you raise your voice, please? Increase your voice.
Hypertensive encephalopathy.
Okay, so can be hypertensive encephalopathy. Good. What else?
Hydrocephalus.
Hydro. Okay. Hydrocephalus. You said can be. Okay. What else? Can be something in the sinuses.
Sinusitis?
Yes, sometimes chronic sinusitis, but we will argue about the typical presentation of increased intracranial pressure because sometimes we see some infection like sinusitis, like we saw one child with vertebral abscess. It was presented typical of increased intracranial pressure. So sometimes near infection to the area of the brain can give some like that. So if this patient has dog, what can be the cause?
If this
There is
patient has what?
a very famous infection come through dogs.
Oh, dog.
Encephalitis.
Hydatid cyst. It is a cyst which can infect and cause something like brain infection. Of course, brain abscess can occur, but as you said, Dua, our top priority is to rule out the cause of increased intracranial pressure because it is emergency. So, what investigation you will consider?
In this case, because of his presentation of increased intracranial pressure and his inability to walk that's getting worse, I would opt for CT, emergency CT over MRI.
Okay, what type of CT?
Contrast enhanced CT.
So to do CT with contrast, what do you need to do? Any investigation first?
His allergies.
Other?
Renal.
Yes.
Renal profile.
Renal profile. Why? Because this contrast.
Eliminated through the kidney.
Yes. Also, you need to do, and that is why you will teach during your practice. You are multitask person. You are going to consider while collecting the blood sample upon admission. We are thinking about the differential diagnosis. We are requesting CT. We may need to get opinion of other specialty. You must be able to work with a team as a team. Okay, to finish many jobs. At the same time, you must be ready for treatment, for investigation, for counseling the family. That's why the doctor is always have a busy time. Okay. So CT with contrast.
Let me present.
What else? Did you want to go ahead for lumbar puncture?
No, because I'm afraid of herniation.
Yes. So in every situation, you must have warning sign and warning intervention. Hello?
Sorry.
In every situation, we have warning sign as Azhar spoke about, and warning intervention. You are not hurry to do lumbar puncture. Otherwise, if the pressure is so high, you can cause herniation. That's why many prefer to do CT before going ahead for lumbar puncture. Okay? It is very important. So if you did lumbar puncture, what did you suspect to see?
Maybe there can be hemorrhage if there is a hemorrhagic stroke.
Okay.
So it can be bloody.
Okay.
If I can also look culture it or to add evidence of infection for meningitis.
So what you will see in case of meningitis?
It will be cloudy.
No, there is an important sign known as meningeal enhancement. It means the blood vessel which is crossing the area of meninges will be very clear and very prominent due to infection. So meningeal enhancement sometimes can diagnose meningitis. Okay? Meningeal enhancement, it will appear in both CT and the MRI, and it is very important clue for the meningitis.
Okay.
Especially if you are not able to do LP due to increased intracranial pressure, or sometimes the patient has a rash or infection at the lumbar area. If you are going to do lumbar puncture, you are going to insert infection. So it is contraindicated for some situation. If the platelet is very low, you are afraid it can bleed. So there is some limitation. It may be the decision is correct, but the situation around is not so easy. Okay.
Okay.
So don't forget to do the basic investigations, either for infection, either for electrolyte examination, or your examination to rule out meningitis and other infection. Okay. To go deep for the history, but our top priority is brain tumor. I think in some study I found that sometimes it is more than one year to diagnose the brain tumor, because some patient has family history of headache or migraine, or they are thinking about eyes and the sinusitis and the tooth, and spending the time until it is became frank like that with eye manifestation. It is very dangerous. It means now we started to come to the optic chiasma. I think you have one patient also presented late because he was diagnosed as cyclic headache. So the family got comfortable and forget Panadol is available, and the mother tried another stronger medication for headache. But when she came to us, she came late. Started to sequence like that. When the neurosurgeon opened, he cannot debulk the tumor. He said, if I do complete bulking, I would let her completely blindness. That's to say, our goal is to early, and remember that, please, our goal and our responsibility is to try to early diagnosis of the patient, not late, until it became complicated with a bad prognosis. Okay? So can we see the OSCE, and then we will continue our discussion?
I will share my screen.
Afika share ke?
Ada zero kan? Fiz. Hello? Ingat ke?
Dengar.
Everyone see my screen?
Dengar. Can.
Okay, so we proceed with the first OSCE.
Okay. Who will answer?
So for this picture, it is strabismus. To be exact, it is azeotropia. Physical examination to test or confirm. You can do cover or uncover test. And possible causes, it can be congenital, infection, malignancy, that's all.
So which cranial nerve is affected now?
The sixth cranial nerve. Doctor.
Lateral rectus muscle that supply lateral rectus muscle. It is the sixth cranial nerve that supply the
Sixth
lateral
cranial.
rectus muscle.
Yes. Yes, that's very important to remember that the sixth cranial nerve is the longest nerve, so that it is the first one to be affected in increased intracranial pressure. But you must be able to differentiate between the sixth, the fourth, and the third sequence, because the eye itself can give you the answer. Yeah. Can you answer?
Okay, so
Okay.
because earlier, so this is strabismus, specifically esotropia, which is the inward turning of the eye. And the physical examination or test to confirm the condition. First, for screening, we can do corneal light reflect test, where we just shine light to both of the eyes. As you can see in the picture, there is a difference between the center of the eye, between both eyes, from the left, right and left eye. Can you see? Can you appreciate the difference, the position of the corneal light reflect?
Yes.
And
Yes.
second, is covered and uncovered test. This is a very simple bedside test we can do. I would like to show a video, but I'm not sure whether you can play the video. Can you see the eye movement
Yeah.
from the video? Huh?
Yes.
Sorry.
Yes.
Not
Yes,
so
yes.
much.
This one is the affected eye is the left eye. If you can see when the doctor move uh, move the cover, so the eye will move. Should I play? Look at the left eye. It will move inward. Inward to outside. You see now? You see?
Yeah.
Yes.
Yes.
Okay.
So the most important first test is the eye movement. Fix the head and do the eye movement. It will tell you, is it, what type of squint is it? Okay, because if it is fixed, not changeable, it means it may be paralytic. So just if the fix the head and see the movement, it will tell you, is it paralytic or non-concomitant or unconcomitant. After that, you will give the torchlight to the eyes and see. It must come to the center of the pupil. If one in the center and the other in the periphery, so it will give you clue for squint. The third one is the cover test or cover uncover test. Okay, so it will give you details about the latent squint. Okay. Next.
So this is the next question.
So this is endoscopy examination. Findings, I think there's an enlarged optic disc and it's showing there is a papilloedema. I'm not sure there is another signs, but I can enlarge swelling. Enlarge this, name the condition, papilloedema, maybe secondary to increase in intracranial pressure. And when it's associated with C and 6 palsy, it is called isolated cranial palsy or false localizing signs. Because C cranial 6, there is a long course in the intracranium, so maybe due to the pressure effect, due to the increase in ICP, so causing the presentation of the C and 6 palsy.
Yes.
Am I?
Yes, all your answers are true.
So repeat it again. Repeat the answer again, please.
Okay.
Okay, for number 1, all the questions, Doctor?
Yes.
Okay, so the examination is fundoscopy examination. Okay, for the findings, it shows that there is enlarged optic disc swelling. So I think this condition is papilloedema. Might be second.
It is a large and
like
cupping.
swollen.
Cupping, swollen and the cupping. It looks like cup. Okay.
For cupping. Okay. I forget the term. Sorry, Doctor.
And there is vessel crossing there.
The rim.
Okay.
Okay. And then for the condition is the papilloedema, might be secondary to increased intracranial pressure. Okay, and then when it is associated with C and 6 palsy, it may be it is called as isolated C and 6 palsy or false localizing signs because of the C and 6 palsy, because of the pressure effect due to the increase in intracranial pressure.
Okay, do you need to add anything, Fika?
No, she already answered it all.
How come she answer all this? MashaAllah. Super student? Are you super student or you are favorite colleague?
I live outside.
Okay. Next one, don't forget papilloedema. And this is an important issue for me, please. Try to catch everything. Don't be hesitated to start early. If you find someone can teach you how to go to the ophthalmoscope and see the fundus, don't hesitate. Every point you are teaching now, it will help you in the future. Now they are speaking, all the world is speaking about real-time ultrasound. You just, if you know how to put the probe and see for every part of the body, it is very, very easy. Okay. So if you start early while you are young, you will get a lot of knowledge and the ability to screen for many things. Okay. Next one.
So this is another symptom of increased intracranial pressure, which is bulging of fontanelle. Can you see it?
Yes.
And this is also another symptom of increased rate of ICP in a younger patient, where if the suture is not closed yet, so there will be hydrocephalus with increased head circumference.
Okay, remember that any crossing more than 2 centile must be taken seriously. Again, any crossing the centile for any measure more than 2 centile, you must take it seriously. Okay, go ahead.
So I want to answer the next question.
Okay, I would like to try. So this is the CT scan of the brain. So and then describe the finding. From what I can see, there is a dilated lateral ventricle, and then there is also loss of sulci and gyri of the brain. And then name the condition. I think this hydrocephalus. So name the condition. Okay, possible causes of the cerebral edema. Okay, maybe also possible causes of the condition can be due to the if hydrocephalus can be divided into communicating or non-communicating. So for the non-communicating, it could be due to obstruction. So it is the most common cause is aqueductal stenosis. Okay, and then for the symptomatic treatment for this patient, I think one of the treatment we can do a shunt if it is obstructive. Okay.
Ventilation.
Okay, so
Okay.
So it is I'm not sure if we can see this is actually a contrast enhanced CT brain. And then as you can see, it is the findings are dilated central ventricles and also effacement of the sulci and gyri. And this is a condition of hydrocephalus. And as Fitria said earlier, the possible causes of this hydrocephalus can be divided into two, obstructive or non-obstructive causes. And also the symptomatic treatment for this condition is the most easiest is VP shunt, ventricular peritoneal shunt.
Okay, but put in your mind sometimes if there is brain atrophy, so it looks like maybe compensatory hydrocephalus. It is extended because the space is not so occupied. Okay. At the same time, you must go through the history. It is very important. Even a radiologist, it is for the exam, it will be more clear if came to you CT like that. But even the radiologist will not accept any to report anyone without giving them detailed history. Because sometimes you can differentiate between two diagnoses by the history. Okay. So please, if you are going to refer to any radiology, you must write all details. Like if this patient has severe birth asphyxia and what is this, and got global developmental delay and the microcephaly, it is different than he has got infection and got hydrocephalus like that. Okay. So it is very important. Thank you. Next.
So this is another size of CT scan, the same CT scan. As you can see, there is a hypodense lesion here. So this is indicating where the tumor is. And then if we do MRI, we can see a better tumor lesion at pontine area.
Yeah, it happened with us with many cases. Can you come back for the first?
First? Yeah.
So the first also show any signs of, here we cannot pick it. So you must know the limitation for every investigation you are doing. Okay? And even during our counseling for the family, we are going to do rapid CT scan to rule something. It is not the top, we may need further investigations like MRI, which is not easy and they need appointment and like that. So if someone tell the family CT is okay, just dilatation, it is assuring maybe we need to follow up like that, is completely different than with the history you have that patient has increased intracranial pressure symptoms and signs. And okay, so you must know the limitation. You must contact the radiology department, writing in all details related to the case. Okay, this is a good point. Okay.
So this is the last question. You want to answer?
So for the name of the procedure, it is lumbar puncture.
Mhm.
Indication, if we suspect infection such as meningitis or TB or syphilis, or sometimes if we suspect multiple sclerosis. For, uh, for the contraindication, if there is risk intracranial pressure due to risk of cerebral hydration, and then if there is thrombocytopenia or other bleeding problems, and if we suspect there is final epidural access or skin infection at the site of epidural puncture. For the complication, it can be post-lumbar puncture headache, infection, bleeding, cerebral herniation. That's all.
Mm. So all the answers are true. So this is the spiral set of
Okay, it is here is
lumbar puncture.
an important. Do you need to add anything, Africa?
Unstable.
Me, you are
Hello?
lagging.
Hello?
Okay, dah okay.
Okay.
Silakan.
Here is a very important point, please, for us during practice. Usually, most of the patient, when you came to the area of lumbar puncture, you will find some resistance. Okay. And we will not be honest if we said, okay, it is for them. Alhamdulillah, I got rest. I was going to do maneuver and they refuse and I will. No, it is not like that. Okay. The ability to be honest and clear is very important. Okay. Honest, clear, sympathized person. You will tell them this patient need LP. We are afraid to hear that someone got paraplegia due to the lumbar puncture or like that. You will tell them everything has its own danger, but it is very rare. And we are doing this test many times. Hopefully we didn't see. If you ask anyone, I used it to tell them about that. If you are driving the car, you can get accident. If you are walking in the street, you can get accident. It is a matter. Everything, if you said can. It may be someone in distance area got this complication. So yes, it can, but usually we are doing it very common. We didn't experience any complication because we are putting all precaution. We are doing it under complete septic technique. We are giving sedation for the patient. We are using the correct needle. We are putting it in the correct place. We are away from nerves like that. And at the end, you tell them, I would like to tell you one message. If this is my baby, I swear I will do it for him. So she feels that your heart is understanding her feeling and afraid, but you must be honest because sometimes if you didn't do for meningitis, even I counsel a very good mother. Really, she agreed directly when I speak to her, mom. It is for the benefit of the baby if it is positive or negative. Alhamdulillah, it came negative. I tell her, you see, now after 2 days, I can tell you, go home, please. If I didn't do, I need to continue treatment for 10 days or 14 days because I am not sure. So you must be able, please, to counsel, and your insist is the best benefit of the child. Okay, thank you. Do you have any questions?
Doctor, I have one question.
Yes,
In regards to this case, because the boy is already 7 years old,
yes.
just I want to ask, is there any rule to measure the head circumference in this child, as we usually measure up to 3 years old only?
Yeah, we can measure the head circumference, because even for any case of hydrocephalus, if I feel that the head circumference of the child is big, I will measure the head circumference of his mother and father to rule out like familial hydrocephalus.
Family.
And there is a rate. Of course, the skull now is closed, and this tension now is apparent, but why not? You can measure. But it is not the top knowledge for you, but must be recorded.
Okay,
Okay.
doctor.
Okay. Any other question? Good. We finish standard time, 60 minutes. Okay, very good. So our next session will be
I will be the patient.
Fitraya. Okay.
I'll be the doctor. Farhana will be the doctor.
Okay.
Alright.
Who will be
I will
the
be the patient.
yes? Who will be the Uski? Non-human Uski? Well, non-human.
Aiman.
It will be me, doctor.
Ayman. Okay. So we have Fitraya, Farhana, and Ayman. Okay.
No, me, Afika, will be the patient, doctor.
Afik. Okay. Good. Go ahead.
Alright. Okay. Assalamualaikum. I'm Afika. My name is Farhana. I'm a medical student. So ask history from me today.
Farhana, can you raise your voice a bit?
Is it clear now?
Yes.
Alright. Yeah. Assalamualaikum. Puan Afika. My name is Farhana. I'm a medical student. Can I get your permission to get your history today?
Yeah, sure.
Alright. Can you introduce yourself and your child?
My name is Afika. You can call me Puan Afika. I brought my son today, Adam, 11 years old.
11 years old. Okay. Okay, may I know the reason for your visit today?
The reason I came is because my son suddenly developed rash for 1 week.
All right. Can you explain more about the rash, Puan?
With regards to the rash, it was sudden in onset, and there is multiple reddish and purplish color of the rash started suddenly at the sole of my son's feet.
Okay.
And then,
Can you?
yeah, and
You,
then I noticed that the rash extend proximally to the upper part of the lower limb.
from the foot to the upper part of the lower limb. You
Yeah,
mean the
it involves the legs, the knees, thighs, and also buttocks.
buttock area? Okay.
Yeah,
Both limbs.
both limbs.
Right. Do you have anything else to add?
Mm, with regards to the rash, if we touch, we can feel the wrist surface.
There is a what?
The rash wrist.
Raised. Okay. All right. Is raised. Okay.
Yeah.
Is there any pain or itchiness from the rash? Does your
No, my son didn't complain of pain or itchiness.
any discharge?
No discharge.
No discharge. Okay. This is the first episode.
Yeah, this is the first episode.
There was no history of trauma or anything before this.
No.
Alright. Okay. No history of trauma. Okay. Is the rash only at those sites? Are there trunk on the chest area or the abdomen area?
No, only at the lower limb.
Only at their lower limb. Okay. Do you is there any other symptom other than the rash?
Apart from the rash, my
Yeah,
son also complained of abdominal pain.
abdominal pain. Okay.
Yeah,
Yes.
when I asked him, where is the pain, she just said, her abdomen. So I thought it is generalized.
Generalized.
Yeah,
Did was it associated with like eating food outside?
no, we eat at home.
You eat at home. All right. Was the abdominal pain during after the patient got the rash?
Yeah, 4 days after the onset of the rash.
Did you notice if the pain was increased by anything? Did anything aggravate your son's abdominal pain?
So when I want to touch the abdomen,
Yeah.
he said that the pain increased.
Sorry?
The pain increased when I touch the abdomen.
Oh, okay. Did you give any medication?
Uh, yeah, I give painkillers,
Give what type of painkillers for it?
paracetamol.
Oh, and did the pain subside?
Yeah, but the pain came again later.
Oh, it's recurring, you mean?
Yeah,
Okay. All right. Did your son vomit?
uh, no,
There's no vomiting?
no vomiting. But today my son suddenly developed loose stool.
Loose stool.
Yeah,
All right. Today.
today.
All right. How uh how how was the frequency before?
Uh, Before usually 1 to 2 times per day, but today it is 5 times.
5 times per day.
5 times for today.
Alright. Did you notice anything odd with your son's stool?
Mm,
Was there any blood or was it black?
the color is still brownish,
Hmm?
but it become watery.
Watery. Still
Yeah.
brown, watery.
Mm.
Alright. How about was there any abnormal smell or blood?
No,
No.
no smell.
Alright. Was there any reduce in oral intake? Like your son suddenly doesn't want to eat?
Yeah. Yes.
What about drinking?
Normal.
Normal
He
drinking.
drink as usual.
Sorry?
Huh?
Can I hear?
He had reduced oil intake.
Reduce oral intake. But what about oral intake? You mean eating or both eating and drinking?
Both.
Both. Okay. Does he seem dehydrated? Like, is he thirsty? Does he appear tired?
No, he is still active.
Still active.
Yeah.
Alright. What about any fever before this?
What?
Did your son experience fever?
No fever.
No fever?
No.
What about any cough or sore throat, runny nose?
Mm, I think before the onset of the rash, 1 week prior, he had cough and runny nose.
1 week prior?
He had cough and runny nose.
Oh, no fever, just cough and runny nose.
Yeah.
All right. Can you tell me more about the cough and runny nose?
Mm, the cough just minimal. It is non-product. It is productive, but it occurs only for 2 to 3 days.
All right.
With regards to runniness, it is minimal in amount.
Sorry, I cannot hear
Minimal.
the runny nose.
Yeah.
Was there sore throat? Sorry, my point. I can't hear.
Sore throat. I'm not sure about that.
You're not sure. So, did the cough and runny nose resolve by itself, or did you go to the GP?
Yeah, it resolved by itself.
All right. What about any pain at the joints? For example, the knee joint or the elbows. Was there any joint?
My son didn't complain any joint pain.
No joint pain. Did um, no joint pain. All right. What about your son's urination? Did you notice if he had any change in his urine color, like red colored urine or dark colored urine?
I'm not sure about that because my son didn't complain anything regarding the urination.
Okay, okay. All right. What about his face? Did your son have any like facial puffiness?
No,
No. Did he experience any like shortness of breath?
no,
Did his limbs appear more swollen or his abdomen more swollen?
no, it's just normal,
No,
as
it is
usual.
okay. What about I want to ask about bleeding tendencies. Did you notice if your son had any mucosal bleeding in the mouth?
Mucosa?
Um, gum bleeding. Gum bleeding.
Oh, no, no,
No gum bleeding. What about
no,
like easily bruising?
no.
No easily bruising. Okay. All right. I want to ask whether your son complained of any like neck pain or if he had any pain when he looked at the light.
No,
No.
I
Okay.
don't,
You don't think so?
no.
Oh, okay. All right. Do you happen to live in a dengue-prone area? Was there any fogging recently, Puan?
No,
No.
yeah, no.
Oh no. All right. All right. Have you guys been jungle trekking recently, or had any water activities?
No, because it's PKP, so we only stay at home.
Sorry, I cannot hear.
Because of PKP, we only stay at home.
Because of what?
PKP,
Sorry, I can't hear what.
movement
MCO.
MCO. Oh, okay. All right. So no jungle, no sports, no water sports or jungle activities.
yeah, no.
Did you notice any like rat infestation in your house?
No, there's no yet.
No. All right. All right, Puan. And can I ask about your son's birth history? Was there anything during?
Mm,
Uh,
what?
was there anything significant for his birth history? For example, did you have any problems during pregnancy or during the?
When I pregnant with him, I had a thyroid swelling.
You had thyroid?
Yeah,
Oh, all right.
but I was on follow-up, but no medication was given.
Oh, you. Oh, okay. All right. What about your baby?
My baby, it was I delivered normal at 41 weeks.
All right, normal. The birth weight?
Birth weight 3.7 kilograms.
Did he have any complications?
No,
All
he is
right,
healthy.
healthy. All right. What about the nutritional history. Did you breastfeed your son?
Yeah, I breastfeed until 6 months.
6 months only?
Uh, uh, yeah,
And then you gave
and
him
then I give formula milk
milk. Was there any reason you stopped breastfeeding?
because I'm working.
You're working. Okay. And then what about his food? What is his menu, normal food intake?
Currently, he take normal like us.
Or an adult diet?
Yeah,
Is he?
usually I give him rice, chicken, and he likes to eat vegetables.
Oh, he likes to eat vegetables.
Yeah.
Okay, that's good. So he's not a picky eater.
Yeah, no.
He allergic to any foods?
No, no.
All right, good. All right. What about? I want to ask about his development. Can he go up and down the stairs? Can he dress himself and tie his shoelaces?
Yeah, yeah. He can do everything by himself.
He can do everything by himself.
Yes.
What about his speech, language, and social?
Good. He
Good.
can he can tell the events that happen to me
Ah,
that
okay.
happen at school.
All
Yeah.
right. What about his immunization? Did you give him his vaccination?
Yeah, yeah. I follow the schedule.
You follow the schedule. Okay, that's good. All right. Can I ask about your family, whether any of your family members had any history of easy bruising before?
No.
Okay. And I want to know about yourself when, like where are you living, your age, your husband's age, and your children.
Uh, we live in Taman Impian. Currently, I am 34 years old. My husband is a lorry driver, and I am a nurse.
Okay.
Mm.
How many children do you have? One?
3 children.
2 children?
Yeah,
So your son is the first child or the second child?
yes. The first child.
How is your second child?
My second child is healthy.
Healthy. Does your husband smoke?
No,
No. Okay. All right. Okay. Oh, I want to ask if there's, by chance, do you know if there's any history of lupus in the family, like an autoimmune disease?
what lupus?
Autoimmune disease.
Autoimmune. No, I'm not sure about that.
Any history of malignancy in the family? Like leukemia?
No,
All right. Okay. Was there any abdominal swelling from your child?
no.
I'm thinking of what to ask. Okay, I think that's all.
Okay.
How much time do I have left? 3 minutes? Wait a second. 3 minutes.
You still have 1 or 2 minutes. It's your chance to arrange your mind. Okay. So now can you tell us?
Summary.
Yes, please.
All right. My patient, Adam. Um, 5-year-old Malay boy with no known medical illness came with complaint of red purplish painless rash, which was not itchy for 1 week duration. It was palpable and raised, most likely it's palpable purpura from the sole up to the bilateral lower limbs, the buttocks, and the upper limbs. Also associated with dull, aching abdominal pain for 4 days post rash. It also was associated with diarrhea for 1 day duration and reduced oral intake. However, no notice of any symptoms of dehydration, and there was no history of eating outside. It was not associated with any fever or any other. Sorry, there was no fever. However, there was cough and runny nose 1 week prior to the rash, with no history of any arthritis or arthralgia. Um, there was no history of passing out melena. There was no hematuria or any history of passing out frothy urine, proteinuria. For relevant negative, the patient is not in a dengue prone area, and there was no history of jungle trekking or doing any water sports, and there was no history to suggest any meningitis such as neck stiffness, photophobia, or vomiting. Also, there was no history of easy bruising or history of autoimmune disease in the family or malignancy in the family. That's the summary, doctor.
Okay, so what is your working diagnosis now?
Right. Since the patient, a boy, a Malay boy, had possible, I think, palpable purpura over the lower limb buttocks, bilateral lower limb and buttocks, with previous history of upper respiratory tract infection, with abdominal pain. I think the possible diagnosis can be henoch-squalene purpura, which is what I think the child most likely has. All right.
Okay, differential diagnosis.
Right. So for differential diagnosis of the patient, um, it can be due to, even though it's lower down the limb, can be due to the rash due to systemic lupus erythematosus, or but because there's no joint pain. Sorry, I take it back. Because there's no joint pain, most likely it's not SLE and also not GIE. It can be immune thrombocytopenic purpura because there was history of upper respiratory tract illness, and also other causes of rash. It can be due to any other infection. Neoplastic causes such as leukemia can also be possible, but since the patient doesn't have any history of malignancy in the family, then less likely. Any other causes of rash? Oh, meningococcal septicemia. The patient did not present with any fever or any symptom of meningism. Right. Yeah.
Good. This is a good point that we must be ruled out as we speak for. Some cases must be ruled out. Why? Number one, it is very critical cases, and if not diagnosis, it can lead to mortality and morbidity. Okay. Number two, what investigation you are going to do for
For
this case?
right, for this case, Firstly, I would like to do complete physical examination, check the skin, also do the all the other investigation. Then for laboratory investigation, I want to do full blood count first. Since patient present with bruising, rash, red rash, I want to see whether it had any reduction in hemoglobin, or if there was any infection, there can be increase in total white blood cell count. Also, if in HSP is a non-thrombocytopenic purpura, so most likely there is no change in the platelet count. And then if it's HSP, patient can come with complication of HSP, renal complication. So I would like to do renal profile to see whether patient has any evidence of whether it's a renal failure due to a nephrotic or nephritic syndrome. And then I want to look at the coagulation profile to see if patient does actually have any cause of prolonged ABTT or BT to suggest bleeding tendency. And then to see if patient has any ongoing inflammation, do C-reactive protein. And then I'm not sure if it's commonly done, but serum IgA, since HSP is due to immune complex formation. It's IgA mediated, so the IgA may be raised, but I don't think it's commonly done. And to rule out whether it's autoimmune causes, to rule out if there's any complement level reduction to complement level. And sometimes patient with HSP can come with GI bleed. So I would suggest you do stool occult blood test for the patient as well. All right. Since I said hematuria, then I want to suggest doing urine flow examination UFIM to see whether there is any micro or macro hematuria, which can be due to HSP, and also the complication of which is nephrotic syndrome, so nephritic syndrome. Yeah. Anything?
So it looks very big list of investigation.
Yeah.
Which one will diagnose HSP?
Functional diagnose. To diagnose HSP, I read about this. They take the sample of the area where there's purpura on the buttocks, and they check. Yeah, I'm not sure.
So it is a skin biopsy.
Yeah, skin biopsy.
So you didn't mention skin biopsy. So if we change our way of thinking
Yes.
and said hematural purpura usually is a clinical diagnosis, which can be diagnosed by skin biopsy, mostly by skin biopsy, but we need to do basic investigation to rule out some critical cases like autoimmune diseases, CLE, like whatever, kidney, blah, 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 blah. Okay. So you will not do it for every patient unless there is, and this is a very important place because we have a lot of diseases which come by a rule. You rule out if you are 10 candidate now and I can know the 9, so the remaining will be that one. Okay, and it is very important, please. But during your actual practice, you must be cautious not to miss an important diagnosis like SLE if there is other criteria. So because it can be a part. Also, you will ask yourself, what is the prognosis?
Usually the prognosis of HSP is good because it's usually self-limiting.
is the meaning by good for you? Is it good for me? So what is good?
Good because it is self-limiting. So usually the child will we usually just give the child supportive treatment and then they'll recover.
So we'll ask your colleague, you can collect your baby and goodbye. We didn't need to see you again. I can understand that. Did you agree? Baba. Where is our patient?
Patient Africa?
Yes.
Yes.
Did you agree for that? Still your prognosis is very good or good. So can we discharge you? Hello. Can we discharge you?
No, I don't agree with that because my child is in pain.
Number one, he is in acute condition. Okay, if your child, okay, not in pain now and he doesn't experience some complication like abdominal pain, like interstitial, like that, can we discharge you? I mean discharge, خلاص, no need to make follow up.
We do follow up. We do follow up.
Why? You tell me it is a good prognosis.
Unfortunately, some patients do experience complications from HSP, so we must be cautious about that, such as what doctor said, interception and also the kidney problems, renal failure, whatsoever. So yes, we must do TCA for the patient.
So that our own words can affect the situation. I mean, it is completely different to give the patient a piece of assurance, but it doesn't mean this is my complete summary for the issue. So I will tell him also, despite of a good prognosis of this disease, but we used it to find some of these patients experience like hematuria or experience like hypertension or experience like some few complications which can resolve with time. So we need to follow up the patient usually for about 1 year. It is the same like for glomerulonephritis. It is the same for some diseases which has a good prognosis. You are not able to give 100% assurance, or your assurance is just to make it simplified. But the word but, we need to see him regularly to check his blood pressure to make sure that there is no affection, because what is the mechanism of this disease?
Systemic vasculitis.
Yes. What is the meaning of systemic vasculitis? So it can affect which organs?
Can affect gastrointestinal, most common.
Joints. Cause pain. Okay, joint. Cause arthritis.
Renal. Can cause glomerulonephritis, and also it can, to severe form, can go to intracranial also.
Okay.
And others like cardio can cause carditis.
Okay.
Conjunctivitis.
So tell me, which type of vessel are affected?
Small vessels.
Where is the small vessel is present?
The small vessels?
Yes.
The organs.
Within the papillary dermis?
Everywhere.
Oh, yes.
It's everywhere. Every cell of the body. So it can affect any organ on the body. Because if you read, you will find some studies that they found brain, HSCP affection. You will find genital or ovarian or testicular. You will find a lot of affection because it is vasculitis. So it can affect. So you must be honest and clear. This is some sort. That is the issue. It's some sort. of inflammation or autoimmune affection of the small vessels, which is present everywhere. Our main concern is about the kidney, about the joints, about the abdomen, about the intussusception. But we must follow up your baby in spite of a good prognosis, and this is our usual practice. But we cannot tell small child to go ahead and do now. We must support him for some time. It is the same. Okay, please. With time, we got experience of how even to said the words in Islam. He said, من قول إلا لدي رقيب عتيد. Every word we are going to say, either it is written by the angel on the right or on the left, according to is it correct or incorrect. But even in the word, now we are practicing that. If you said the patient some word, it may be cause either bad effect. Before, we used to write like ventricular induced pneumonia, ventilation induced pneumonia. We are calling it, and we are very happy because we can remember VIP. But when they did study, they found something. Really, the ventilator will not induce pneumonia. Okay, it is the issue that when you put the tube, there is a secretion which not the patient are not able to cough, so it will stay in the lung. If any microbe came, it will cause pneumonia. So they changed and said ventilator associated pneumonia. They occur together. They came together because of the normal mechanism of the body, not us, because they found it. Some patient said, so why you put my patient in ventilator if you know that it will cause him, it will induce him pneumonia? So it is associated, not 100% associated. We are trying to decrease this association, but don't even this small word, because it cost in America, I think, a very big number of claim against the doctor there. So they changed it. So even our words, now we are speaking about mental retardation. We are not preferring to see this word now. We'll speak about intellectual or educational problem or intellectual disorder. No need to say mental retardation in front of the family. It is sometimes looks like you are making injury for the family of the patient. No need to say dysmorphic features. He is dysmorphic, yes, but you can say abnormal facial features. He has abnormal feature. What is dysmorphic means? It is something, some word which can be. So we are trying even to consider to use our words, which is an important sense. If we put it in our mind early, we will not cause trauma. Because sometimes you are doing a very good job for one patient, but you give him tough word, he became unhappy. It is the same. The God himself sometimes may be not happy because you are not keen about your words or about your transfer of knowledge. Can we see the Oski?
Yes. Can you see?
Yes.
Okay. Okay. So this is the first one. Anybody wants to volunteer? Anyone?
I think I try.
Okay.
So it is a macular rash. From what I see, it is macular rash. Red in color, located at the leg, starting from the ankle up to upward to the mid thigh, and it is mostly at the dependent side, which is the back of the leg.
Can you give any possible causes of the rash?
It can be HSP. Other than that, like mentioned previously, ITP.
Yes.
Uh,
Okay, so Alia, that's what Alia described, and I think she's correct, which is the multiple macular rash. But we need to examine it properly. We need to palpate the rash to see if it's palpable or not, because in some cases, the palpable rash can help us in diagnosing the disease such as HSP or meningococcinea. I think maybe some Kaposi-sarcoma or Rocky Mountain spotted fever. However, I don't think that's quite common in our region. So, related to this case, so this is the presentation of Henox-Scan HSP, which is palpable, red to purple purpura, mainly at the lower limbs, the thigh, buttocks, which are below the waist. And they may also be presented with other symptoms such as abdominal pain, joint pain, according to the affected organs.
I think you must comment, please, about this is a leg of child who looks to have some swelling of the joint. Okay, the way you are presenting yourself, it reflects to the anyone hearing you, how you are thinking, what is the knowledge inside your hard disk, the brain. Okay, so it is very important to see this is a leg of child who looks to have some like arthritis or enlarged joint with rash. I can see near the buttock, so it looks more to the extensor. I would like to do the berberic test to see it is fading or non-fading, and to examine some area on the body like the buttock to see if there any rash. I would like to check the abdomen if there is severe abdominal pain or mass indicating intussusception. It's your chance if you got some case like that to do like Muhammad Salah. You can bring a good goal. Okay, am I clear?
Yes, sir.
Yes, sir.
So please, it's your chance now. If you have a good chance like that and a common scenario and you know it, so try to present yourself, your knowledge. Try to tell the one in front of you, because I found most of you in front of external examiner a bit reluctant to speak. Why? You are not doing a show for yourself. You are doing show for the care of the patient. You are conclusive doctor. You are comprehensive one. You know what is in front of you. You know what you must be excluded like that. This is a very important one. Okay, so if you have 2 or 3 knowledge, don't give it by piece. Go ahead. If they tell you go ahead, speak. Okay, am I clear?
Yes, doctor.
Okay.
Yes,
Yes,
sir.
sir.
So this is the next one. I would like to invite anyone to interpret this. Volunteer. The TC is for the TC is white cell count and DC is differential count. Anyone?
Okay, let me try. For hemoglobin, I think it's normal for 11 years old child. And then TC apa tadi? Total white cell.
White cell.
So total white cell is within the normal range. This is usually 4 to 10. DC, I'm not sure what is that.
Differential count, polymononuclear, lymphocyte, and eosinophil.
Oh, okay. So I think all are within the normal range also. For ESR, usually 12. So it's also not raised in this case. And platelet count is slightly lower. And then
why slightly lower?
Because the normal range is 450. 400.
Again, this is memory in fault. No, this is memory in fault with here. Take care. It is very dangerous during the exam. What is the normal platelet count?
150.
Sorry,
150 to 400.
Yes, for that, yeah.
So she went to the upper limit. So
sorry. Yeah.
So what is the definition of thrombocytopenia?
Less than 1 to 5.
150. Okay. How can we say that it is mild or moderate or severe? Answer. What is thrombocytopenia? Based on what?
The symptoms and also.
No, symptoms is a big important issue for transfusion if needed, like bleeding like that. But to divide it mild or moderate or severe, you must know that, please. Okay. What is the definition? How can we define the severity by the lab? And sometimes you need to do, as I told you before.
For mild, it is 100 to 150.
Yes.
For moderate, it is 50 to 100. For severe, less than 50.
Yes, and the critical, if less than 20. Okay. So it is very important to know that. At the same time, we need to ask sometimes about the blood film to show the platelet itself, because platelet sometimes is bigger size or smaller size. It goes with some syndrome. Even the count is normal, and sometimes also there is diseases known as thromboathenia. I mean, this thromboathenia, the platelet looks normal in number, but its function is low. So with time, you will build our knowledge to know that, okay? So this CBC is normal or abnormal?
Actually, this is normal.
It's just normal.
Of the blood count.
Okay.
I would like to point that in HSP, compared to other types of opera, the platelet count is normal in HSP. For example, like in ITP, the platelet count is lowered. Also, if there is any leukemia or leukemia, it is thrombocytopenia.
Is it clear? That's why we said this is a diagnosis of exclusion. Okay. Next slide.
Okay, next slide. This one. I'd like to invite someone.
Who will be our future lab specialists?
So this is a red cell cast.
Yes. And can you state possible causes?
So the possible causes will be the glomerulonephritis.
Bayilo?
But
Red cell cast is pathognomonic for
glomerulonephritis.
glomerulonephritis, not Bayilo.
Glomerulonephritis. Yeah.
Yes.
So, can you document again in that film for your colleague, please? Where is that castis? Where is the red cells? Where?
Okay. So this is red cell cast, which are the accumulation of red blood cells, which are due to damage in the glomerular or tubular damage. Is features of glomerulonephritis, which can happen due to various causes such as HSP, post-strep, lupus nephritis, and other various causes.
Okay, good.
Accumulation.
So what is the? Okay, very good. So castis means they are now boycotting and collected together. Okay. Crowded. Okay.
Anything you like to add to that?
Is there any more slides?
One more.
Okay.
For the next slide. Okay, this is a like scenario. Please give a diagnosis and possible investigation and expected finding, and also management if possible.
I would
Yes,
like
please.
to answer. So, this patient, he presented with abdominal mass and also red current jenis stool. So the diagnosis could be intussusception. So I would like to do abdominal ultrasound to look for donut sign.
To look for what?
Donut sign.
Are you hungry?
No.
Okay. Okay. If you did X-ray, also can help you.
Yes.
May help you. So, how can you diagnose? Sorry, how can you treat?
Any?
How can we treat intersusception? Sorry?
Surgical emergency?
Any other answer?
Anybody would like to try?
Enema.
Very good.
Enema.
No, not barium. Don't use barium enema here. Use enema. Can be contrast like gastrography, not barium, because if there is what is this? If there is leaking, I mean there is rupture in the intestine. If you put barium and go to the peritoneum, it will be severe irritant. But you will give like gastrography enema or some even using air enema. They push air slowly. Sometimes it will be released. So why it happened with HSB?
It happened in HSP because of vasculitis, damage to the to the vessel's wall, causing bleeding, extravasation of fluid. So this area of extravasation, it causes I don't remember the term, the point where intersusception can happen.
So it is the apex now, the area of vasculitis. It will make the intestine like heavy, and the intestine will invaginate on itself. Okay, that's why if you pick it early and send it for radiograph, sometimes they are able to manage it without surgical intervention. If you became late and they are afraid that this piece became gangrenous or ischemic for a long time, they may need to make it surgical. All the diagnosis suddenly became, yes, very good.
So this is the characteristics for interception, which happen due to the mucus mixed with blood and stool. So it become like this. It's a food actually, red currant jelly. That's why I call red currant jelly.
Okay.
Appearance. Then on ultrasound, transvaal ultrasound, you can see there's target lesion or what Fitria said before. We can also call donut sign. On long axis, you can see, like, I think this is it, the telescoping of the intestine. That's all for me.
Okay. So now we got an important lesson about some diseases which can be diagnosed by exclusion of other, because it's to do skin biopsy like that, sometimes it is not available and can be easily interpreted like that. So you must be able to understand all these points. Okay. The other point, also our rule here is to rule out some dangerous cases like leukemia, like ITB and others. Okay, or severe infection. We know that our message must be very clear to the patient, and try to practice that. You must be honest, clear, frank, and sympathize at the same time. Now, differential diagnosis of berbera we spoke about. What about differential diagnosis of arthritis? It's your own turn. You must prepare it, please. Okay, you must prepare differential diagnosis of arthritis. If I have arthritis, what can be the cause? If mono, if pussy, if polyarthritis, it is very important. Please don't forget that, because diagnosis of arthritis is very important, and I think you got orthopedic, and you must be good in that. But from the medical point of view, what is the most common cause of monoarthritis?
Septic arthritis.
Monoarthritis. Septic arthritis or trauma, of course, can be also, okay. But polyarthritis can be
GIA.
Okay.
IBD.
Okay.
Rheumatic fever.
Rheumatic fever.
So at the time when you come to a point like this, you must try to be systematized, divine it as a groups, okay? So you will not miss. Is it infectious? Is it autoimmune? It is systemic disease, okay? It is very important. Even leukemia must be forgotten, because it will cause also arthritis, okay? Thank you for your nice presentation, okay? Do you need to ask any questions now?
No.
I have a question, doctor.
Yes.
Do we do serum IgE for HSP at all?
As a routine?
Hmm.
Me, myself, I will not do, unless there is a clue for some complication. Okay, because I think we read some article that the glomerulonephritis also diagnosed to be HSCB, glomerulonephritis, diagnosed as monoinfectious mononucleosis. Sometimes you may even go to renal biopsy, but most of the cases, if you did the basic investigation and ruled out like by the full blood count, no thrombocytopenia, by the blood film, there is no blast cells, by the other examination, organ function is okay. I think we have the courage to initially assure the family and follow up the case for few days that it's free of complication.
All right, doctor. Thank you.
But as I told you, means discharge doesn't mean goodbye, see you for other case. No. Sometimes you can discharge the patient from the ward, but he need to come and you tell him, I need to see you after 3 days. You must teach how to measure the blood pressure, or logbook, like that. Okay, because hospital cannot tolerate all the residents. Okay. Thank you. See you,
Doctor, I would like
inshallah.
to ask one
Yes.
more question. Can
Okay.
for the management of HSP, we usually just giving patient the supportive management such as like analgesia if patient is in pain or hydration. I would like to ask if when
But
do we want
the
to give
bin, yes,
uh,
yes, continue.
when do we want to give patient like steroids?
Yeah, there is indication for steroid also. Analgesia is acceptable one. Assurance, of course, number one. Analgesia is number two. Number three is expectation for any complication. But if the patient experience severe abdominal pain or other criteria, we can use a short course of steroids. Me myself doesn't prefer to be hurry to go for steroid unless there is a symptom, because really we see a good result with observational or conservative treatments. Okay, but can be considered, of course. Okay, thank you, and see you inshallah soon.
Thank you, doctor.
Hoping inshallah the best for you, and if you have any concern anytime, you can contact me. Please don't forget to do the full blood count and the differential count and the blood film and the other business, because if it is clear, it will make your life more easy. Okay? Always ask yourself what can be the differential diagnosis and what is pros and the cons and the cons for this diagnosis. Okay? Thank you. Assalamu alaikum wa rahmatullah.
Thank you
Thank
so
you,
much,
Doctor.
doctor, for
Thank
your
you,
Thank you
doctor.
time.
so much, doctor.
Thank you,
Thank you,
doctor.
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 Thank you, Doctor.
Alaikum
Assalamualaikum.
assalam wa rahmatullah. I cannot leave. Why?
Okay, okay, doctor.
Who can close it? I cannot switch off.